Welcome back, BloodStream listeners, to another episode of Ask the Expert. It's your host, Amy Board, and wow, 2025 has really been a year of exploration, evolution, and growth in bleeding disorder care. What felt like a scientific dream not that long ago is quickly becoming real, and patients are beginning to feel that shift every day. On this episode, we've gathered all of our experts from the season. Dr. Tammy Singleton, Dr. Mark Redding, Dr. Amy Dunn, Dr. Ben Samuelson-Jones, Dr. Patrick Ellsworth, and Dr. Janice Stabler. As we look back on the ground we've covered this season, let's start with a quick word from our sponsor.
Rich lives with hemophilia A. He enjoys gardening, home improvement projects, and traveling. But what you don't see is how living with hemophilia has impacted his ability to live an active life. Rich bravely shares his experience living with this rare disease, its impact on travel and activity, and the importance of overcoming hemophilia's impacts to do what you love safely. Scan the QR code or click the link in the show notes to hear Rich's full story and learn more about how living with hemophilia can impact travel and activity.
Thank you again to our sponsor, Sanofi. We could not do this show without you. And now, as we wrap up season 1, we're zooming out. From the fundamentals of the clotting cascade to the promise of rebalancing agents, from inhibitors to women's inclusion to safety. A clear story that took shape this year. We've heard it described a lot of different ways this season. Waterfalls, dominoes, bridges, even cement. It's complicated. But understand it is the foundation for understanding every therapy that we've talked about. So let's go back to the basics. We're going to hear from Dr. Amy Dunn and Dr. Ben Samuelson-Jones on what exactly is the clotting cascade.
Basically, anytime there's injury of the blood vessel, there is sort of initial chemical signal that goes up, and the end goal is to make something called thrombin. And to do that, you really need a whole cascade of things to happen, which is why it's called the clotting cascade. It used to be called a waterfall. The different clotting proteins basically work like a series of dominoes, right? One turns on the next, turns on the next, turns on the next, and eventually everything works together to form a stable clot. But you also need platelets and von Willebrand factor to form that clot as well. The platelets and the von Willebrand factor are that initial plug that fills that initial hole, and then all of the numbered clotting proteins come down over top of that and make a stable clot. So it's complicated, and it's remarkable that it ever works right.
Your blood has to do this amazing thing. When it's in your blood vessel, it has to be liquid to carry all the nutrients around, and as soon as it leaves the blood vessel, it's supposed to fill that hole where it left. So it has to very quickly go from liquid to solid at the precisely right time. When the blood's in the wrong place, it's supposed to be solid. And there's a cellular component of that, and that's mostly in the hemostatic system. That's mostly platelets, but the other blood cells, like white blood cells and platelets, and the cells that line the blood vessels, they all play a role. And then the solution part of the blood, the acellular part, the part that doesn't have the cells, has a bunch of proteins floating around, and they also contribute to this hemostatic system. And that's really the coagulation cascade. And to form that solid plug, output of the coagulation cascade is insoluble fibrin. So that means that it comes out of solution and forms like a web. And you can think about that as like platelets and other cells are forming a plug, and then that this fibrin web sits down on top of it, but it's really like a cement. It fills in all the nooks and crannies and just plugs that hole. So that's the final output. And how it does that, and it has to do this very quickly because you want the blood to recognize that it's in the wrong place and then very quickly amplify that signal of being in the wrong place to form this web and cement. And it does this with the coagulation cascade. And what that is that's a series of proteins that are in a latent or inactive form, and then they're sequentially activated to do their biological thing. And the central mediator is making thrombin, and that does a lot of stuff. So the thrombin is what converts fibrinogen to fibrin, which makes that ultimate web. But it also then feeds back and amplifies the signal. And so it gets kicked off with what we call the extrinsic pathway, combining factor 7. And tissues factors is one of the ways that the blood recognizes that's in the wrong place, because you're not supposed to have tissue factor exposed to your coagulation factor. So once it's exposed, the 7 becomes, it's really 7, activated factor 7 becomes activated. And that results in making a little bit of thrombin. And then that little bit of thrombin then feeds back and kicks off an amplification loop. And it directly activates factor 8 and indirectly factor 9. And that's why when you're missing factor 8 or factor 9, you can't kick off that. You're missing that whole amplification loop. And that's why you end up making less thrombin and therefore have trouble plugging that hole.
When factor 8 or factor 9 is missing, the cascade simply cannot amplify the signal, and bleeding follows. That's the gap rebalancing agents step into, by not adding more, but by dialing down what's working against clot formation. Let's hear from Dr. Tammy Singleton.
When we're talking about a rebalancing agent, we are still talking about a way to have a goal, to have a clot to form when we need it, but it's just happening in a different way. So instead of replacing what's missing, we now have an opportunity to think about the entire coagulant system in terms of procoagulants and anticoagulants, because your body has both. And how could we still have the needed and end goal results, like that end result of having clot formation so that you don't bleed? How can we have that by looking at the two things that are involved, procoagulants and anticoagulants? And if you're missing some of the procoagulants and the scale is now tipped a little bit, right, like this, so you don't have enough of those procoagulants over here. And so you're heavier right on the body's natural anticoagulants, the body's natural defense system, right, to prevent clotting, prevent too much clotting. So you're heavier on this side. So bigger person sitting on the scale over here, lighter person over here. So how do you take some of the weight off on this side? Take away some of those natural anticoagulants. So now you do this. And you're now back in a place where instead of having that scale tipped, you're now in a place where you can have clot formation that way. You didn't replace what was missing. You took away a little bit of another part of the system, the body's natural anticoagulant. So that's why we refer to them as rebalancing agents.
If you're missing any portion of the coagulation cascade, you can have a bleeding disorder. And many of those disorders don't have factor replacement because it's too rare and no one has commercialized it. For example, factor 5 deficiency, the only way to replace the factor 5 is with frozen plasma, which is how we treat hemophilia 70 years ago. So the whole idea of rebalancing is that people with bleeding disorders don't have enough of the procoagulant factors. They don't have enough factor 8. They don't have enough factor 9. And so instead of replacing what you're missing, the idea is to remove some of the anticoagulant power. There's 4 main components of the anticoagulant system: protein C and protein S, antithrombin, and then TFPI, which stands for tissue factor pathway inhibitor. And all of those are being investigated to see how well they can rebalance the bleeding problems in hemophilia A or hemophilia B. And so the idea is that you have a certain level that you're missing on the procoagulant side, and you try to bring it down on the anticoagulant side so that your thrombin is similar to where you were if you had the quote unquote normal amount on both sides. But it's really complicated, right?
When we're talking about hemostasis and thrombosis, it's all about how much thrombin and where is it? Because it's got to go to the right place and you've got to make enough of it. And if you have hemophilia, you can't make enough of it. On one side, your body wants to clot, and that's like your factor 8, your 9, your 10, your thrombin, prothrombin. And on the other side, you've got your protein CNS, your antithrombin, your tissue factor pathway inhibitor. It's been an interest for a while since the genome was sequenced that, hey, can we leverage these proteins that we know are there and the way they act to treat bleeding disorders, which, spoiler alert, you can.
And with all that in mind, many listeners asked the big question. If factor replacement works so well, why do we need something new?
In some ways, hematology is pretty simple. If you're missing something, you just put back what you're missing. And so if you're missing factor 8, you give back factor 8. And that traditionally has been done, or it's done now, with either plasma-derived concentrates or factor 8 that you make in the lab, or factor 8 that you make in the lab that you bioengineer to make it last longer or work better.
The rebalancing agents, because no one else has come up with a better term than that either. Amy. We have 2 on market now, right? We have concizumab and marstacimab. They actually fall in the same category. They're tissue factor pathway inhibitors. And the thing that is nice about both of those drugs is that they're subcutaneous administration.
Factor replacement therapy does work pretty darn well, and we've been doing it for a long time, right? So one of the big downsides of factor replacement therapy is that these medicines have to be given through an IV. So you have to use an IV infusion. And in a lot of people, that's really hard. So the burden of the treatment, because of the way it's administered with factor replacement therapy, is I think one of the things that's really pushed forward the development of some of these new drugs, because the difference with them in terms of how they're administered is these newer drugs that we're talking about are given as a subcutaneous injection. So like you would give yourself a dose of insulin. It's still with a needle, but you don't have to stick it into a vein and squirt it in there. You just have to put it under the skin. So these drugs last longer. And so you don't have to do those subcutaneous injections every day. Some of these medicines you do once a week. Sometimes you can do them every other week or every month, or maybe even every 2 months, depending on which medicine you're using. So they don't have to be dosed nearly as often, and the way of getting it in is subcutaneous instead of IV. Those are probably major drivers. The last thing I would say is that these newer drugs, these rebalancing drugs that we're talking about, they will work regardless of which type of hemophilia you have. So they'll work whether you have factor VIII deficiency, hemophilia A, or factor IX deficiency, hemophilia B. They work for both. And they also work even if you have an inhibitor. So if you're somebody who's made an antibody against factor VIII or factor IX, these drugs will still work.
These shifts don't just change treatment plans. They change what patients and providers talk about during a bleed, during travel, before surgery, and the everyday movements that used to require immediate treatment.
As we approach this sort of shift in care with all of the new therapies that are available, and we would say if a patient living with hemophilia had a bleeding episode, we were like, treat, have a bleed, treat. And then we said, you have a bleed, you're on another agent, call, chat, pause, pontificate, ponder. Hold on a second. Hold on. Be ready to treat, communicate, right? And then we can come up with a collective plan, because the cadence will change a bit.
If you have a bleed, I would say it depends. When I started, these agents were really early on in their development phase. So I started with mostly short-acting factor products and then the extended half-life. So in that time frame, we used to always just say, if it hurts, treat. We just assume that if you get hurt, it's a bleed and you should treat right away, immediately, before labs come back. Now, our mindset has changed a little bit, because both for the factor VIII mimics and these longer half-life products for factor VIII and for these rebalancing agents, we want to make sure that it's really outside the norm. And it's not that they can't treat, we just have to maybe think about it.
And when we zoom out even farther, the potential of these therapies extends beyond hemophilia alone, especially for rare bleeding disorders and those with inhibitors.
The most exciting thing about these rebalancing agents is that they, by their very mechanism of action, will work for any inherited bleeding disorder. And I know that's not how they're currently being studied in clinical trials. And I'm not advocating any off-label use or anything. I mentioned that people with factor V deficiency, for example, the only therapy that do replacement is plasma. And so they are decades behind people with hemophilia A. But you would rationally think that the mechanism of action, if you decrease factor V, decrease in any of the other anticoagulant factors that we talked about, it is most likely to be similar as in patients with hemophilia A.
If I think about what are currently the biggest unmet needs in hemophilia, I mean, we've got a lot of really good treatments for hemophilia, like you said, but there still are some big unmet needs. The first one that comes to mind is folks that have hemophilia B and a factor IX inhibitor. That's not a lot of people. So hemophilia B is less common than hemophilia A, and not that many people with hemophilia B make inhibitors. But for those people who do, we do not really have a good treatment for them still.
Those are things that I'm interested in too. And even looking at things like emicizumab and MIM8 for those rare deficiencies, even repurposing them, so to speak, is something that I'm interested in looking at and hopefully can get there, because opinion time here. Everyone's got opinions about kind of industry and academia and how they interact. But I do think industry have done a lot of good things for patients in the hemophilia space. They've made factor and medications available for people all over the place. But because that incentive isn't necessarily going to be there to develop a whole new drug for a very rare specific factor deficiency, I think that's where repurposing these sort of more universal type agents like the protein S antibody could be a big win for industry and for providers and patients, that we'd have kind of something that's there for everyone.
So as we've talked about who benefits from these therapies, another theme kept emerging: women. Their participation, their symptoms, their exclusion, and their potential impact.
There's just been a long history of not including women because of menstrual bleeding. And I've gotten the question before, how are we going to track it? I'm like, how do we do it now? We see that these women are iron deficient and miserable and bleeding too much. So like you would track it by seeing, are they still bleeding so much and are they iron deficient? Yeah, that's another population that, whether it's a factor VIII mimetic or one of the rebalancing agents, that could potentially really be a huge help. And the other thing is just that I think there can be a bit of a sense of, especially if the primary symptom is heavy menstrual bleeding, that it's just what you normally do, but more. But no, you are creating iron deficiency from blood loss. This is abnormal hemostasis. This is abnormal bleeding. And so some of it, I think, is just people minimizing the bleeding that a lot of women with bleeding disorders experience in the first place.
Historically, women have been excluded from most drug development in the hemophilia space. They've been included more in the von Willebrand or platelet dysfunction space. And that's really because there are so few women who have severe forms of hemophilia. And frankly, patients of all sexes that have mild and moderate hemophilia have been excluded from almost all clinical trials as well. It's a bit trickier with women, particularly if they're of childbearing age, right? But pregnant women participate in clinical research all of the time. So I don't think it's insurmountable. And I know that women participate in clinical research for all sorts of other drugs when they're not pregnant. So I don't think it's insurmountable. So I would love to see more clinical trials for all of those groups, whether you're male, female, or whatever your factor level is, whatever disease you have. I think we really should be studying all people who could benefit from these drugs.
We now have an opportunity to really focus and provide better care for a lot of those patients. And that includes people who don't have a Y chromosome. So that includes all the XXs out there and all the XYs out there. Those of us who are living with hemophilia, we now have an opportunity to address it, I think, across the board. So really a phenomenal opportunity to do what we do best. And there is no shortage of need and no shortage of work.
Throughout all of this, one message stayed steady from every expert that we spoke with: safety matters.
As we talk specifically about antithrombin and rebalancing agents and reducing antithrombin, there are nice guidelines that have been provided from the manufacturer that sponsored, conducted the clinical trials, and approved by the FDA in terms of how we should monitor those antithrombin levels. So it is important that we follow that. It is important that we continue to think as individuals and provide care to individuals. Because again, first it starts off with, are you a good candidate for this? And if you are a good candidate, and I may be a good candidate, and we may have the same condition, but you are not, because it's more than just the diagnosis, right? You may have other things. You may have a family history. You may have other conditions. And it's hard to compare because you can maybe explain barely what's happening to yourself and understand it like yourself, but to explain it so someone else understands it. So you have to know that's going to be something that's going to be between the provider and the patient to first make the determination if a therapy that is reducing antithrombin, that's a rebalancing agent, is really going to be right for you. And if it is, magnificent, then you're going to have a plan in place to follow those antithrombin levels. Again, there's guidance that is provided to follow those levels. There's guidance that is provided in terms of where to send those levels. There's guidance that's provided in terms of how to treat breakthrough bleeding. And there's guidance provided in terms of how to have a surgical procedure, how to adjust dosing like when needed. So you really need to have this individualized care provided to you by someone who understands how to use the product, understands you, and understands your condition.
Just like factor, right? When we do factor replacement therapy, we don't just give a huge dose. We give a specific dose to get the factor level to a certain point, enough to get the job done, but not too much, because remember, too much clotting, too much hemostasis becomes thrombosis. So one of the things we learned is that we got to be careful that when we do rebalancing, we don't overdo it. Should patients be afraid? I would say no. I don't think patients should be afraid. The whole goal of clinical trials is to figure out the safety part. And if these drugs aren't safe, they're not going to be approved.
We went through a long period of time where factor 8 and factor 9 were really the only options that we had. And now there's different brands and different flavors and multiple different things.
And as Dr. Singleton reminded us this season, clinical trials and the people who participate in them make all of this possible.
Education and experience is powerful, because what it has taught me personally is if I have a condition, one of the first things I ask, in addition to, listening to my doctor and talking through, all the steps and things that I have to go through, I go, is there a clinical trial I could participate in? Do you have anything? Do you have any observational studies that are open? Can I go anywhere? I can travel, so I'm willing, to participate. So what do you know? I go to clinicaltrials.gov for myself and my family. I want to see, is there something I can participate in? Because if I have this condition, I want to receive the best care possible, but how can I give back and help too? And how can I change things? And whose shoulders am I standing on in terms of the giants that came before me? Because if you're offering me some therapy, you're only offering me some therapy because a few hundred people signed up to participate in a clinical trial to say that it was okay for me to receive this. I want to pay it forward too. I want to recognize that. So for all of us, this entire community, people living with the condition of bleeding disorder and the providers, where is the clinical trial? And so where is the observational study? If you're living with a rare condition, we can't find you. Did you know that? We can't find you. You have to stand up and be counted and be accounted for.
As we wrap up season 1, we want to leave you with that energy that every expert voiced at some point this season. The excitement, the possibility, the fact that bleeding disorder care is changing faster than ever before.
These drugs are super exciting because they're new. They work through novel mechanisms of action, and they might work for stuff outside of hemophilia, which is TBD. But we're pretty excited about the potential of these. And I don't know, I think a lot of it is anytime there's something new, we're excited to get our hands on it and try it.
I think the thing that excites me the most about treating people is that they are just that. They are one person. And what's right for one person is not what's right for everyone else. So having this array of options, I think, allows me to individualize to the time in life, the activity level that the patient wants to have, if they need a surgery, if they need to travel for a period of time. So, there's just going to be lots of different options that should allow us to really help that person make hemophilia the least important part of their day.
Hair bleeding disorders are rare diseases, and you have one of the most rare ones. That's always a challenge, and that's not always where the commercialization is focused. But that is what's most exciting to me, to be honest.
So whether something is right for you or not, we can talk about that, right? You talk about that with your provider. But just to have the opportunity to talk about them, to learn about them, to ask the question, is this right for me? Hey, what is that? Can we talk a little bit more about that? How exciting is that? And how blessed are we to be a part of it?
Kevin lives with hemophilia A. He enjoys hanging out with friends, cooking, and playing guitar. But what you don't see is how living with hemophilia has impacted his communication style. Kevin bravely shares the hurdles he faced in communicating about his hemophilia with friends, family, and providers, and highlights the importance of transparent, patient-focused conversations that go beyond treating symptoms. Scan the QR code or click the link in the show notes to hear Kevin's full story and learn more about how living with hemophilia can impact communication.
And that's a wrap on season 1. The clotting cascade, rebalancing agents, inhibitors, women's involvement, safety, and everything that makes this moment in bleeding disorder treatment is so exciting. To all of our experts, a deep thank you. To all of our listeners, thank you for learning, thank you for questioning, and thank you for showing up. We'll be back with season 2, where we'll go deeper, answer more of your questions, and explore the next wave of innovation in bleeding disorders care. I'm Amy Board, and this has been Ask the Expert. Stay curious, take care, and we'll see you next time. Did you know BloodStreamMedia.com is your one-stop shop for all podcasts for the bleeding disorders and rare disease community? There, you can find links to the Global Hemophilia Report and our flagship podcast, BloodStream, with your hosts, me, and Patrick James Lynch. Also check out Flow, which is straight talk about extreme periods, and The Pain Pod, which is an in-depth storytelling odyssey of chronic pain. All this and more on BloodStreamMedia.com, the #1 podcast network for rare disease. Have an idea for a future episode of Ask the Expert? Or have a question that you would like to hear one of our experts answer? Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream Media on Facebook and on Twitter and on Instagram and all those social media channels. I am your host, Amy Board, and until next time, stay curious, my friends.